Stepwise therapy for type 2 diabetes mellitus. A structured escalating approach to managing type 2 diabetes. Intensifying treatment only when glycemic targets are not achieved at each step. Step 1. Lifestyle modification. It is the foundation of type 2 diabetes mellitus management and should begin before any pharmacotherapy is considered. In many patients, effective lifestyle changes can significantly improve glycemic control and may delay the need for medications. The first component is diet control. Patients should reduce refined carbohydrates, increase fiber intake, and limit overall caloric intake. These changes help reduce postprandial glucose excursions and support better metabolic control. The second component is physical activity. Regular aerobic exercise, along with resistance exercise, improves insulin sensitivity, allowing the body's tissues to utilize glucose more effectively. The third component is weight reduction. Even a modest reduction in body weight can significantly improve glycemic control, decrease insulin resistance, and lower cardiovascular risk. These measures form the cornerstone of type 2 diabetes management and should continue throughout treatment even after medications are started. Step 2. First-line drug therapy. After lifestyle modification, the next step in the management of type 2 diabetes mellitus is first-line drug therapy. The drug of choice for most patients is Metformin. It is started when lifestyle measures alone fail to achieve the desired glycemic targets. Metformin has remained the preferred first-line agent because it is effective, well-studied, and has a favorable safety profile. Its major action is to reduce hepatic glucose production, thereby lowering fasting blood glucose levels. It also improves insulin sensitivity, allowing peripheral tissues to respond more effectively to insulin. An important advantage is that metformin does not cause hypoglycemia when used alone because it does not stimulate insulin secretion. Important contraindications for metformin use include significant renal impairment and conditions associated with an increased risk of lactic acidosis. Step 3. Dual drug therapy. The dual drug therapy is considered when metformin alone is insufficient to achieve glycemic targets. At this stage, a second agent is added based on patient characteristics and comorbidities, allowing treatment to be individualized. One option is glimepiride, a sulfonylurea that lowers blood glucose by stimulating insulin secretion from pancreatic beta cells. Another option is sitagliptin, a DPP-4 inhibitor. It enhances endogenous incretin activity and is often chosen as a weight-neutral option. Empagliflozin, an SGLT2 inhibitor, is particularly valuable because of its proven cardiorenal benefits, making it an excellent choice in patients with cardiovascular disease or chronic kidney disease. Pioglitazone, a thiazolidinedione, improves insulin sensitivity and may be useful when insulin resistance is a major concern. Finally, liraglutide, a GLP-1 agonist, not only improves glycemic control but also promotes weight loss, making it especially attractive in overweight or obese patients. Step 4. Triple drug therapy. It is considered when dual therapy fails to achieve adequate glycemic control. At this stage, 3 agents from different drug classes are combined to produce synergistic glycemic control, meaning each drug targets a different mechanism involved in hyperglycemia. The foundation of most regimens remains metformin, which serves as the backbone of all regimens because it reduces hepatic glucose production and improves insulin sensitivity. The second component is commonly a sulfonylurea, such as glimepiride, which enhances insulin secretion from pancreatic beta cells. A third agent is then selected according to the patient's clinical profile. Options include a DPP-4 inhibitor, an SGLT2 inhibitor, or a GLP-1 agonist. These agents provide additional glucose lowering while offering benefits such as weight reduction, weight neutrality, or cardiorenal protection. The key takeaway is that triple drug therapy combines complementary mechanisms from different drug classes to achieve better glycemic control when dual therapy is no longer sufficient. Step 5. Insulin therapy. It is considered when adequate glycemic control cannot be achieved despite multiple anti-diabetic medications. The goal is to progressively intensify treatment while mimicking normal physiological insulin secretion. The first step is usually basal insulin. A long-acting insulin, such as insulin glargine, is added to the existing oral therapy. Basal insulin primarily controls fasting glucose levels by providing a steady background insulin supply throughout the day and night. If glycemic control remains inadequate, treatment is intensified to a basal bolus regimen. In this approach, rapid-acting insulin is administered before meals in addition to basal insulin. This provides coverage for postprandial glucose excursions and offers more complete physiological insulin replacement. The full stepwise pathway. The key principle is treatment escalation in a logical stepwise manner based on the patient's response to therapy. The first step is lifestyle modification, which includes dietary changes, regular physical activity, and weight reduction. This remains the foundation of diabetes management. If glycemic targets are not achieved, the next step is metformin, the preferred first-line pharmacological agent because of its efficacy, safety, and low risk of hypoglycemia. When metformin alone becomes inadequate, treatment progresses to dual therapy, where a second drug from another class is added. If control remains suboptimal, triple therapy is introduced by combining 3 agents with complementary mechanisms of action. Finally, when oral and injectable non-insulin therapies fail to achieve adequate control, insulin therapy is initiated and progressively intensified as needed. The most important point to remember is that each step is initiated only when the previous step fails to achieve glycemic targets, ensuring that treatment remains proportional to disease progression while minimizing unnecessary complexity and adverse effects. Choosing the right add-on agent. After metformin, treatment should be based on individualized decision-making rather than a one-size-fits-all approach. First, consider patients with cardiovascular disease. In these individuals, drugs with proven cardiovascular benefit are preferred, particularly empagliflozin and liraglutide, which have demonstrated reductions in cardiovascular risk. Next, in patients with obesity, weight reduction becomes a major goal. Therefore, a GLP-1 agonist or an SGLT2 inhibitor is often preferred because these agents promote weight loss while improving glycemic control. For a cost-sensitive patient, affordability is an important factor. In such cases, sulfonylureas or pioglitazone may be considered because they are generally less expensive options. Current guidelines particularly favor SGLT2 inhibitors and GLP-1 agonists in patients with established cardiovascular disease, CVD, or chronic kidney disease, CKD, because of their additional organ protective benefits.